Hi everyone, welcome back to this video. This is Virgilio's case 57, which is specifically right calf pain with walking. So we have here a 65-year-old man presenting with 5-month history of worsening, progressively worsening right calf pain with walking. He describes the pain as a tightening or cramping, and it comes on after walking for 2 blocks. The pain forces him to stop walking and is relieved after he sits down for 5 minutes. So it does have relief. The pain comes on consistently at the same 2-block walking distance each time, unless he walks fast or uphill, in which case he can walk much less. He denies waking up at night with pain in his foot. He reports a 40-pack year smoking history and is taking antihypertensives. He has 2+ femoral pulses bilaterally, but a non-palpable popliteal dorsalis pedis and posterior tibial pulses on the right side, and diminished same pulses on the left side. He is moderately obese, yet both legs appear to be thin. The skin on his lower legs appear to be thin and shiny, flaky, and dry, with no hair. His toenails are thickened. There are no ulcers in his feet. Capillary refill is diminished in his right foot at 4 seconds. Laboratory values reveal a total cholesterol of 280, and so it's higher than normal, a low density lipoprotein of 160, and a high density lipoprotein of 35. So again, we do the same approach each time. And the question that I first ask is, what is the diagnosis? What is the differential diagnosis? This one is a pretty clear sign of, with all of the risk factors that the patient has, all of the physical exam signs of like the thin, flaky, dry, shiny skin, and the lack of pulses, right, bilaterally, but especially on the right side. It is all really coming to show us that this is very likely to be peripheral arterial disease. But then other potential differentials that you would want to think about, right? I think a great tip that one of my family medicine preceptors had provided me is think about at least 3 differentials, and then rank them. Think about justifications for and against them, and then ultimately you come up with your working diagnosis and management plan based off of that. So in this case, my first is probably PAD, but then my second might be some sort of like neurological problem, like sciatica perhaps. And then in association with that, is there potentially some sort of like back pain from spinal stenosis? Is there osteoarthritis, right? And then of course, in terms of the vascular system, another thing that we can think about is it like a venous problem, right? Chronic venous stasis, venous insufficiency. So I already mentioned the reasons for why PAD is the most likely diagnosis. So let's jump right into what would we want to really look for on history and physical exam. So for history and physical exam, the high yield points to note is that we are thinking about, in this case, something called claudication, right? And claudication is when you have like this calf. So we go from bottom to top, the calf, the thigh, the butt pain with walking that is relieved with rest and is reproducible at the same distance. And that's particularly suggestive of what's known as claudication. And this term is actually really important because there's a specific definition in association with claudication. Right. So claudication, it is a reduction of blood flow basically to the leg muscles, right? And there's like a 3-part definition that we want to ask about on history. And the first was that pain that we talked about in the leg with walking specifically. And then when you rest, there is relief with rest. Okay, with a few minutes of rest, which we saw in this case. And then the third is that it is reproducible. It's not just a one-time event, but it's a reproducible pain that happens at the same walking distance at each time. So each time you go a specific X meters, right? It's always recurrent pain in that same circumstance. And claudication is a symptom of PAD. So that's why it's really important to ask about that. And then other things to note is just going back to my high yields. By the way, on this, like I think it's the 4th edition of Virgilio's. If you look at page 642, that's where this high yield summary is. But right, physical exam wise, what would you see? There's like a whole list of different physical exam findings you would see with arterial insufficiency, and that's really what you need to like memorize and say here. So that would be like the pulses, for example, are absent. You'll have muscle atrophy, you'll have hair loss, you'll have dry and atrophic skin, toe ulcers, and thickened toenails. All of those are indicative of PED because if you think about it, if you're not getting enough like nutrients, oxygen to your distal like muscles in the legs, especially, that's where you're going to have problems in terms of maintaining the hair, right? And you're gonna have problems maintaining the skin integrity. And also like there is going to be atrophy of your muscles because you're not able to use them as often and they're not getting enough nutrition either. Okay. And then the next thing that we can ask about is the pathology or pathophysiology, right? So the pathophys of this, it says SFA is the most common site of atherosclerotic disease in the lower extremities. So the pathophysiology wise, SFA is the one that is the most common site of atherosclerotic disease in the lower extremities or Hunter's canal. And SFA stands for the superior femoral artery, okay? And um, just to pull up a video or a picture of that, I'll add that in, but it's like you have your leg obviously, and then the femoral artery is like on this side here. It's a very non-specific picture, but the point is like you want to think about the fact that it is um, the femoral artery that innervates the rest of the calf, and subsequently, it's especially the calf that tends to be affected. And then what is the differential diagnosis? We already talked about some of them, but like neurogenic claudication associated with spinal stenosis is a big one. Arthritis, sciatica, chronic venous stasis. Diagnosis is going to be history and physical exam along with the ABI. So the ankle brachial index with Doppler is what we typically like to use for this. And you can do a CT or MRI angiogram, but only if intervention is planned. Management is going to be conservative for claudication. So there's a different like classification system of Rutherford. And so if you have Rutherford classes 1 to 3, then it'll be conservative, like stop smoking, walk a little bit more, take some statins, take aspirin, right? So we will say conservative. But then also, by the way, the best drug that we like to use, and this came up actually in USMLE Step 1 quite a bit in like NDME practice exams, was like the mechanism of action of drugs and specifically for PD. So like cilostazol is important to note as a drug that is really good for PAD. And the time that we start to get to interventional, which is where you literally have to go in and grab that clot, take it out. It's for classes 4 to 6. I'll talk about the classes in 1 second, but you're having like this in a nutshell is patients are experiencing pain at rest, and then they're also experiencing even tissue loss as a result of the PAD. And the actual invasive treatment options include stenting. So you go in and you do a balloon to push out the clot out of the way so you have a open lumen. You can also do something called endarterectomy, which is where you're like cutting up the vessel and you're taking out that plaque. And there's also surgical bypass, which is you don't do anything about the plaque, it stays there, but then you bypass it by putting a new valve, a new vein, a new R vessel, so that you're able to like just not have to put blood through, or even if blood goes through that occluded area, it's like most of it's going to go through the open lumen, right, of the other vessel that you've put it in. What's the prognosis? Or actually, before we go into prognosis, let's chat a little bit about the Rutherford classes. So I'm just gonna like pull it up here on the Virgilios. It's on page 635 in terms of the Rutherford class system. But the Rutherford class system goes all the way from 0 to 6 classes. 0 is asymptomatic. 1 is you have some mild claudication. 2 is moderate claudication. 3 now is where we get to severe claudication. 4 is now when you're having that ischemic rest pain. 5 is when you're having some minor tissue loss. And 6 is where you're having like severe major tissue loss, right? So as you can see, from 4 onwards is when we're really concerned and we want to not just use like cilostazol, aspirin, and statins, but we want to go in with an actual interventional procedure. And the prognosis for patients with PAD, the 5-year risk of limb loss is only 5% with claudication, luckily, but the mortality, right, due to especially a myocardial infarction is a lot higher. So mortality is going to be associated with an MI. And that is going to be 30% if you don't change, like what we're saying with conservative measures like lifestyle, smoking, taking those statins, etc. So special situations that you should be aware of include subclavian steal syndrome, high yield, right, arm claudication, and dizziness. Um, there's also so the way that you spell that is subclavian steal syndrome, and that's essentially where you're having occlusion of the subclavian. So here's a subclavian, let's say, right? And there's like stenosis here, but then there's like the vertebral artery, and there should be a lumen in this specific area. But then if there's an occlusion here, what happens is that you're going to have reversal of the blood going this way through this lumen. So then you are basically stealing blood away from like the brain, right? To go through the vertebral artery. And subsequently, you're going to get symptoms of like dizziness and like fainting with arm exercises. There's something called Lerick's syndrome. Lerick's syndrome is buttock claudication and absent femoral pulses and impotence. And then lastly, there's also something called Berger's disease, different from like the Berger's test. But Berger's disease is especially young male smokers with distal artery and vein occlusions. And if you look at the first aid book, there's a really good picture of Berger's disease in there. So I would highly recommend you look at it. It's type of vasculitis, and vasculitis is also like more or less important to know, especially for the USMLE Step 1. Okay. And then the last thing to note, ABI is an important calculation. ABI is based on the highest blood pressure of like your basically in the ankle versus in your wrist, like the brachial, and then another wrist, sorry, the brachial artery. So that's why it's called ankle brachial index. And you really want to know that like in terms of calculations, you take it into clinical context. So there could be a falsely normal ABI, but that's because a patient might have diabetes and they might have like calcinosis of their veins or their arteries rather, and subsequently the index might appear to be normal, but then it's not actually normal because of the fact that this patient has diabetes. And the specific measurements of ABI is like for PAD, if you have an ABI of less than 0.9, then that's considered to be associated with peripheral artery disease. And normal is from 1.0 to 1.2. That's our normal ABI. And yeah, there's also gradations within this 0.9, but I think the most important thing to know is that less than 0.9 means that you're having peripheral artery disease, at least based on the diagnosis of this ankle brachial index. So that's everything for this case.